Welcome to NYC Health and Hospitals Kings County's YouTube podcast. I am Dr. Mel Stone, Chief of Surgery.
I am Dr. Valery Rudnitsky, Director of Trauma.
And I'm Fred Harry, Trauma Program Manager.
Welcome to our YouTube podcast takeover. On this episode, we're going to discuss what goes on in the trauma center, what's sort of a daily, what's a day like at a trauma center, because we talk a lot about trauma centers, but what really goes on there. So, Fred, you're the trauma manager. You've been here a long time. You look at all the data. What do you think what typically happens? What goes on? What kind of stuff comes in?
I think quite often folks would think that we see a lot of gory stuff during our days, but I think the cases that really, give us the reason why we do what we do. When I see elderly patients that come in that fall. And something that people don't realize is that many of these patients are on anticoagulation blood thinners, and a simple fall can be a catastrophic event for that elderly patient. So quite often a person may fall at home, and the family may not see it as serious as they think it is, and will delay bringing that elderly patient to us. By the time they get to us, whatever is bleeding in the brain has gone so far that it's now a non-survivable injury. But having said that, I think when those patients come in, we work diligently to rescue them as quickly as we can. And that's where the trauma surgeons like Dr. Rudnitsky come in to take care of these patients.
It's interesting you say that, because if I correct me if I'm wrong, falls is the number one mechanism, meaning how we get trauma in the whole country.
Absolutely.
Right? And I remember before I came here to Kings County up in the Bronx, falls were every day. There was somebody falling. Now, Dr. Rudnitsky, you're probably one of the more experienced trauma surgeons in all of New York. I mean, what about the sensational stuff? What about the big stuff? So we know elderly people fall. That's kind of a natural history of getting old. What can you say some of the big cases that you that stick in your head, working at Kings?
Yes, there is probably at least 30 to 40% of all our trauma admissions, trauma volume, ED trauma visits. They are whatever we call geriatric cases, which is like start somewhere at age 65. Are you there, Dr. Stone?
Yeah.
You already at the geriatric group?
I'm no 65. You say?
Yes.
No, I'm not there
Not
yet.
yet. So
not there yet.
But again, life expectancy is increasing steadily today, especially in United States. People live longer, and as longer you live, there's more chance that you will have some problem and diseases, and so we see more and more geriatric patients. The most recent case, patient that I recall, it was unfortunate gentleman who was actually not in bad health situation in terms of he had some comorbidities like blood pressure and sugar, but everything was controlled. He was frequently visit doctors, but he was I think 90 plus age, and he had problems with his joints and a steadiness with ambulation, and unfortunately he tripped when he was taking stairs, and he rolled down from the stairs like one flight, and unfortunately there was a multiple injuries. There was a head injury, there was a chest injury, there was a broken ribs, there was a broken bones in extremities. So that's
trauma just from
that's what we have to deal with when we take care of geriatric patient. And sometimes it just not even fall from stairs, sometimes just fall from standing or fall from curb that you never would wait for the bus on the curb of sidewalk. Sometimes that small step fall can cause devastating injuries for the geriatric patient. So that's why it's extremely important to have a large support and outside. It's important to go to your doctor, to visit your geriatrician, to be in touch with social worker, and that's how we do take care of patients here in Kings County.
I can tell just by the passion of both of you guys. You're really committed to taking care of the injured, which is a big part of the trauma center's daily life, because this is the more mundane things. This doesn't make the news. But occasionally we have some sensational cases. I don't take trauma as much as I used to, but we recently had a case this summer of a stab wound to the heart, where the patient comes in, there's a stab wound to the heart, we do a little ultrasound, and we find out there's a pericardial effusion, and this means that we got to take this person to the OR and do what's called the medial stenotomy, opening up the chest bone, and it's basically fixing the injury. So basically this is cardiothoracic surgery without bypass, and it's what all of us do. Dr. Rudensky, all of us do. We're not cardiothoracic surgeons, but we certainly do this because we don't have cardiothoracic surgeons here to help us. And this is probably some of the height of what we do, from the very mundane to the sensational. But what I want to ask you though is, what is it? Do you work, Dr. Rudensky, 24/7? How do we keep all these people? These injuries don't happen just all 9 to 5, do they?
Yes, we do have. We must have a trauma surgeon in hospital 24/7.
You mean they sleep here?
They may come.
Those fancy doctors and surgeons in Manhattan, they don't sleep in the hospital, do they? So we sleep here.
Some. It depends. If you work in trauma center or no. We here in the hospital physically, 24/7, and if you would like to sleep, we just don't have time and chance to sleep, because there is a non-stop action that we have to respond in majority of cases like immediately. And just to comment your previous story about stab wound to the heart, we do have thoracic surgeons here in Kings County, but trauma surgeon obligated to take care of any type of patients or injuries, because those many subspecialties surgeons, they don't sleep in the hospital, they sleep at home. And if there is a life-threatening injury, we just don't have time and cannot afford ourselves to wait for that subspecialist to come, because by that time patient may not survive. That's why we've been pushed, to save the life, to act immediately, and sometimes do procedure for thoracic surgeons, for cardiac surgeons, for vascular surgeons.
I'm really glad you brought that up,
subspecialists.
I was only kind of joking about it. Many people who do know about trauma, but lay people don't know that being a trauma surgeon at most trauma centers throughout America is actually like, being a firefighter. We sleep here and we just wait for stuff to happen. So I think that's a big part, and typically because trauma surgery is not like plastic surgery or surgical oncologists, which are all value, people don't know about us. They don't know what we do until they get into a horrible accident. And so, it's a great opportunity for us to have this podcast to tell a little bit of what our life's like. What about some other stuff, Fred? We're going to wrap it up pretty soon, that you'd say would be part of the typical day, you as trauma manager.
Prevention is a big piece of trauma.
Yeah.
So while we do a good job of taking care of trauma patients, we want to ensure that patients don't get injured. I want to just reflect a case. For example, a few years ago, a young lady came to the city. She was riding in the back of a cab and there was an accident, and she was not wearing a seatbelt. And as a result, she was paralyzed. In 2020 November, New York State passed a law that require all backseat passengers to wear seatbelts. This is a good instance in which, had she been wearing a seatbelt, she could have probably not be in the predicament that she's in. So I think taking these steps, whether it's by the state or we doing outreach as a trauma center, makes a big difference in ensuring that these injuries do not occur.
Oh, that's great. You really bring it all back that the best way to take care of injury is just to not have one in the first place. So we're probably going to wrap it up here, but I gave us a little peek into a little bit of what we do in a trauma center on a day-to-day basis.